Thanks, everyone. It's very nice to be here today. Thank you for the nice introduction. I'd like to just start and say that this talk is based on relatively new data that I've had my hands on for about 72 hours, and it's not yet complete. So if people have suggestions for data analyses as I go along, you're very welcome. This is just a very basic seroprevalence study that I'm going to tell you about. Again, just some preliminary data that we've just gotten back, but I think it's very interesting, and actually most of us in Moshi were quite shocked by the numbers that we saw. And more than anything, I think it has really important implications for our patient population in Tanzania. So it's something that I'm very interested in seeing further developments along these lines in the near future. I understand that we're a mixed audience, and so I hope I won't insult anyone's intelligence, but I think some people here might be non-clinical, so I'll just do some basic review of hepatitis so that we're all sort of along the same page. I'm not a hepatitis expert. It is an area of interest of mine, particularly HIV and hepatitis co-infection among children in sub-Saharan Africa. But again, your comments are welcome at any time. You don't have to save your questions till the end. Feel free to just interrupt me as I'm going along. Am I standing in an okay position? Okay, great. So again, I know we have a mixed audience. It's nice to see some familiar faces. Several of you have been to Moshi before. I think a lot of you are very familiar with our work in Moshi, but I think there's probably a handful who aren't that familiar. So I thought, just to start things off, I would just give you a little bit of background on Moshi and on the work that we do there. And then I'll go into some background information on hepatitis, focusing on hepatitis B and C. But as you'll see in my talk, the real focus here is hepatitis B. Those are the high numbers that we've seen, hepatitis C being not common at all. And I'll tell you about the rationale for the study, our methods, most importantly our results, and where I think this could take us in the future. So for those of you who have been to Tanzania, you'll know that it's located in East Africa. There's a detailed map in the center. It's actually bordered by 8 different countries, and it shows a very large border with Kenya. So Moshi is located in the northeastern part of the country, and the map on the right there outlines the region of Kilimanjaro where our collaboration resides, and the red circle is circling the town of Moshi. Most people will know that the Kilimanjaro region is the home of the famous mountain, and so as a result we get a lot of tourists in the area who come to climb the mountain, which stands at 5,980 meters or 960, something like that. It's high. But it's a beautiful place to reside and to work, and those of us who live there feel very fortunate to be there. Kilimanjaro Christian Medical Center is one of 4 very large referral tertiary care centers in the country. It serves a catchment area of about 11 million people, just to give you a sense. The hospital capacity is 450 beds, but those of you who have worked in Africa before know that it's not uncommon to have 2 to 3 patients to a bed, so it very often exceeds that capacity. There are many different departments within the hospital aside from your basic medicine, pediatrics, OB/GYN, and surgery. There's a very large and very much respected dermatology department that's also a regional training center that does a lot of work in albinism and Kaposi sarcoma, just as a few examples, as well as a very large and thriving ophthalmology department. This is the KCRI Biotechnology Laboratory. This is not the hospital laboratory, but this is really a state-of-the-art, DAIDS-approved, DAIDS-certified laboratory that enables us to do the work that we do in Moshi. This is a lab that has excellent standards for quality assurance and quality control so that we're able to participate in international studies, and we're assured that we can believe the results that we're getting. So this has been many years in the making and is functioning at a very high capacity, equivalent to a laboratory that we would send samples to here at Duke. Okay. Just a word on clinical services at Kilimanjaro Christian Medical Center, which we refer to as KCMC. We have a large, what we call the CCFCC, which is a child-centered and family care clinic. I've been active in this clinic since 2007, and most of us who work at KCMC will take part in one of these clinics. It's an exciting place to be. It has a patient population of over 1,600 total that are in care, which if you compare that to U.S. numbers, I mean, these are huge numbers of HIV-infected persons. Children make up about 20% in care, which actually nationally is a larger percentage than most other clinics. It's probably not surprising to you that children traditionally have lagged behind adults in terms of accessing care and treatment for HIV. This place also serves as a training and an attachment center for people within the Kilimanjaro region so that they can come and shadow us here at this clinic and take their experiences back to their own centers where they are from. And of course, it's a big and important place for us to do recruitment for our many research studies that we're involved with. So we provide comprehensive HIV care and treatment services here for children and adults and for families as well. We have a particular day that's devoted just to family care. A large clinic and one that I've been very involved in is our PMTCT, or Prevention of Mother-to-Child Transmission, where we will see HIV-exposed newborns. We now do what we call early infant diagnosis. In the past, we were only able to use an antibody test to diagnose children with HIV. Children can carry their mother's antibodies almost always until 9 to 12 months, sometimes rarely up to 18 months of age. So you can imagine that diagnosis was very often delayed. Now we're using dry blood spot PCR testing for early infant diagnosis, and it's really radically changing the way we're able to diagnose and subsequently care for these children. PMTCT services have expanded dramatically in the last few years, such that just myself, anecdotally as a clinician, I see fewer and fewer babies all the time who are infected because we're doing such a much better job of preventing infection. So it's a really rewarding place to work. Finally, I'll just mention briefly, we have what we refer to as our adolescent or teen club. And most children in Tanzania, to get HIV care and treatment, to get their medications, they must come to the clinic monthly. And you can imagine they have to travel to get there. They're usually missing a full day of school. And so we developed 3 years ago a teen club whereby they come once a month on a Saturday. They all come together. It provides a safe place for them to talk about their disease, to be with like-minded peers with the same disease, often dealing with the same issues. They have psychosocial counseling sessions, we have fun days and activities, and it's really blossomed. We have 100 children in our adolescent clinic right now, and it might surprise you to hear that 99% of these children are vertically infected. Okay, so they were infected at birth, and they range in age from 12 to 22 years of age. So just from a numbers perspective, they've really beaten the odds of surviving their disease. 50% of all HIV-infected children in Africa will die before their second birthday if they're not started on antiretrovirals. Another 25% will die by the age of 5. So if you live beyond the age of 8, you're considered a long-term survivor. We didn't even have medicine to treat these children in Tanzania until about 2003. So they really are long-term survivors, and most of them are doing quite well. So again, another reward of working in Kilimanjaro. Just to mention briefly, there are a whole host of different research activities that go on within the KCMC Duke collaboration. Duke has had a presence there for about 10 years now. And our site has been led by one permanent faculty member for the past 9+ years, and that's John Crump, who many of you may have heard of or maybe have even met. And I just would like to give him, he gets the majority of the credit for bringing our site to where it is today. He's been there permanently and has really helped to make our research establishment what it is. We participate in a number of AIDS clinical trials group and IMPACT clinical trials. IMPACT, without going into the acronym, is the pediatric equivalent of the AIDS clinical trials group. So these are multi-country studies in sub-Saharan Africa, Asia, South America that we participate in, and is a very important function of our site. John Crump has done past studies looking at the etiology of febrile illnesses among hospitalized patients. Currently, he's doing a multi-country typhoid surveillance study that I think is quite exciting. Elizabeth Reddy, who many of you may know in the Department of Adult Infectious Diseases, is my colleague there. And she's done a lot of work in the realm of voluntary counseling and testing, and currently is looking into different measures of HIV testing preferences. One of my biggest projects is looking at our prevention of mother-to-child transmission efforts and looking at rates of infection according to the regimen that the mother and baby received around the time of birth. And then as a second step, looking at resistance mutations among those babies who are infected. There's a huge social bacterial zoonoses grant that John Crump has recently been awarded that should be very exciting. And then John Bartlett, among other things, has a medical education partnership initiative to strengthen the training and educational services at KCMC. And that's just a handful. That's, you know, not even a quarter of what's going on there. There really is a lot of exciting work. Enough about that. I would like to tell you about, as I said, a very simple study looking at hepatitis seroprevalence among children in the Kilimanjaro region. The reason we decided to do this, there were several reasons actually, but one is that we just have very little data in general on prevalence among children in sub-Saharan Africa. Rates of HBV and hepatitis C virus, HCV, are certainly lacking in Tanzania. And then, you know, a big reason for doing this is because we know that children who are infected with particularly hepatitis B virus, well, actually C as well, are more likely to become chronic carriers of the disease. And then they're at risk for a lot of long-term sequelae, which I'm going to talk about. So the global burden of hepatitis B, this is a huge public health problem. There are more than 2 billion people who are infected globally, and an estimated 360 million who are chronically infected. And these people, the risk is that you'll develop complications later in life, whether it's from cirrhosis or hepatocellular carcinoma. We know that sub-Saharan Africa as a whole is considered a high prevalence region, and the World Health Organization defines high prevalence as being greater than or equal to 8%. How high it is in each particular region and each particular country is largely unknown. So what happens if you become infected with HBV, hepatitis B, during childhood? Well, first off, let me tell you, it's very different than if you become infected as an adult, okay? Most of you will know, if any one of us becomes infected with hepatitis B virus today, chances are that we will clear the virus and we will not become a chronic carrier of the disease, so we won't have to worry about long-term sequelae. That's about 95% of healthy people will clear the infection on their own. If you're a baby, a neonate in particular, and you become infected with hepatitis B, 90% chance you'll go on to develop chronic infection, okay? If you're in the 1 to 5 year age group, you still have a 20 to 30% risk. So very different from what we see in adults. And again, it's not that we worry that these children are going to die as children. Most likely it's going to affect them in their most productive years when they're young adults, and they'll develop these complications. They have a 25% risk of premature death due to different hepatic complications. So what do we know about hepatitis B in Africa? How is it transmitted in children? Traditionally, it's always been said that children in Africa don't really get hepatitis B through vertical infection. Now we know in Asia that is very often the case. There are high rates of vertical transmission. It's always been believed for children in Africa that their acquisition of the virus is through horizontal transmission. So you have a household member who's infected, they're playing closely with their siblings, they get saliva all over each other, you know, day to day, they become infected that way in their early childhood years. It's interesting to see that past studies have looked at the prevalence of hepatitis B E antigen among pregnant women in sub-Saharan Africa. So E antigen is essentially a marker of viral replication. If you're E antigen positive, you are much more likely to transmit the virus if you're a pregnant woman to your baby. So in Africa, that prevalence in the past was thought to be around 15%. Compare that to Asia, where rates were more like 40%, which explains why they've traditionally had higher vertical transmission rates. But I'll tell you that this data is quite old, and this comes from the late 80s and early 90s, and there isn't a whole lot of data to inform us now what vertical transmission rates might be in Africa. And this becomes particularly important when you take HIV into the equation and worry that with immune suppression, their viral replication from hepatitis might be much more significant. There was one recent study that was done in South Africa that found greater than 8% of infants less than the age of 6 months were actually positive for hepatitis B surface antigen, a marker of chronic hepatitis disease. So suggesting that maybe vertical infection is on the rise. The answer is we really don't know. Just to talk briefly about hepatitis C, it's also a major cause of hepatocellular carcinoma and liver cirrhosis. Prevalence worldwide is thought to be about 3%. And in contrast to hepatitis B, most people who become infected with hepatitis C, regardless of your age, do go on to become chronic carriers. Mother-to-child transmission is thought to be about 5%, but again, if you're infected also with HIV, presumably your viral loads for your hepatitis could be higher, and transmission rates might be higher than that. So what do we know in Tanzania about hepatitis B and C among children? As I said, there's not a lot out there, and certainly not a lot in the last 10 years or so. If you look, the seroprevalence rates for adults, they range anywhere from 5 to 17%. Again, high prevalence countries greater than or equal to 8%. An older study, but one of the largest studies that's been done, was in 1992, and it looked at greater than 1,000 patients that range anywhere from a year to over 75 years. And it found that there was a hepatitis B surface antigen prevalence of slightly greater than 2% in children in the 1 to 5 year age group, so not really that high, but 12% among those who were school-age young adolescents. And then just in the past few years, these are the only data that I have been able to find. These are all within the last 3 years, looking at hepatitis B and or C in Tanzania. The first one was a cohort of 167 HIV-infected children, only HIV-infected, in Dar es Salaam, which is the capital of Tanzania, quite a ways and quite different from the Kilimanjaro region, okay? And their seroprevalence for hepatitis B was 1.2%. I was surprised at that. I thought, oh, that's a lot lower than I would have expected. Now, their hepatitis C prevalence was 13.8%, and I must tell you, I really question those numbers. I honestly don't believe it. Looking back at their methods, they didn't do any validation of their assays before testing. I really question that data. I don't know that that's a real number. Another study, which was done in Pemba, which is an island off the east coast of Tanzania. Most people are familiar with Zanzibar, so near Zanzibar. Looked at hepatitis B seroprevalence among children and adults, but they did have 97 children in their cohort of children, and it was 4% in children under the age of 4. Again, not that high. And then finally, a study in Dar that was actually just looking at hepatitis B surface antibody results. So really looking at how well our vaccination strategy is working in the country. So children who had evidence of being immune to the disease, presumably because of vaccination. So it was only children born after 2002, because that's when our vaccine program started for hepatitis B. And 69% of them were adequately vaccinated. 1.7% were hepatitis B surface antigen positive.
And
so, yeah.
Before you go on, can I just ask with your HCV, Did they look at that in PEMBA as well, or did they just look at hepatitis B?
They only looked at hepatitis B.
And the reason why I ask is because in the coastal area, there's a lot more intravenous drug use. And
you're
whether
right.
that might be some of what you're seeing, and it would be interesting to know whether they have data from any of the other coastal areas as well.
Yes, that's a great point, Julia. And I'm not familiar with it, but you're exactly right. You would expect perhaps some differences because of their IV drug use in that area. Yeah.
Annie?
Yeah.
How successful is the Hep B vaccination program?
And do you mean in Tanzania
Yes.
in general? I mean, you know, I don't know actual numbers. Looking at these studies, you think, well, why are we only getting 2/3 of those children? Or, you know, is the vaccine, you know, it's a 3-vaccine series. Is it, you know, inadequate for
And
some
that's
reason?
in DAR. You know, in the periphery,
Exactly.
it could be much worse.
Exactly. And, you know, traditionally, most children, what we see is they do come in regularly for their vaccines. If they're going to happen in the first year of life, it's after the first year of life that we really start to lose children. So I don't know actual numbers, but, you know, traditionally coverage has been believed to be quite high. You know, I would think upwards of 90%. But actual numbers, I don't know. The only vaccine I know we have greater than 99% coverage on is BCG, which we do at birth, and that's quite easy. But I would think it would be higher than that. So as I mentioned, my area of interest is in HIV and hepatitis B co-infection. And so just to give you a few words on HIV in Tanzania, prevalence in the country is 6%. So actually not as bad as some of the surrounding areas, and particularly some of the southern African countries that have a much higher prevalence rate. But remember, Tanzania is a country of 40 million people. So from a numbers perspective, this translates into a lot of people, and it's considered one of the highest numbers of people infected in a country. Tanzania has actually done a very good job in expanding their care and treatment for children and adults with HIV, and that's been ongoing since 2003. And currently, there are over 500 health facilities in the country that are providing care and treatment. And all of that is provided free of charge through a government program. But interestingly, there are no guidelines, and we have guidelines that are renewed every few years. There is never any mention about screening adults or children for hepatitis. We do screen them routinely for liver function, so we'll look at an ALT and an AST, but there's never any mention of whether we should possibly be screening them for hepatitis B surface antigen as a marker of chronic hepatitis infection with Hep B. So why do I care about HIV hepatitis B co-infection? Well, certainly, and this won't be surprising to you all, if you are immune suppressed because of your HIV, you are more likely to have reactivation of your hepatitis B disease, or actually even C, if you were previously asymptomatic. When we put children and adults onto highly active antiretroviral therapy, one of the things we always worry about is the potential hepatotoxicity of these drugs. We know that there can be an increased mortality following heart initiation for people who are co-infected with hepatitis and HIV. They get something like an immune reconstitution inflammatory syndrome, which can be quite dangerous. Increased risk of death from liver disease, and again, if you have both viruses, you're more likely to have an increased replication rate of your hepatitis virus, which translates into an increased risk of transmission. So, recent data that we have seen from Kilimanjaro Christian Medical Center actually was an impetus for doing this study. We were recruiting patients for one of our adult AIDS clinical trials group studies, and a requirement for the study was to screen them for hepatitis B surface antigen, okay, to see if they are acutely or chronically infected with hepatitis B. And we only got to about, it was 33 patients when I saw the numbers, and 10 of those were hepatitis B surface antigen positive. And of course you can say, well, those numbers are really small. Yes, they are, but we all sort of, you know, raised our eyebrows and thought, wow, that's quite a lot. What's going on here? So it did, again, raise the question is what really is the prevalence of hepatitis B in particular in the Kilimanjaro region? And my question as a pediatrician is particularly what is it among children? So if we have a patient who is infected with both viruses, as a clinician, I mean, this is something you would definitely want to know. It has a lot of important implications. As I mentioned, we always worry about heart-associated hepatotoxicities. Nevirapine is part of our first-line therapy in Tanzania. With nevirapine, we don't see it that frequently, but the most feared side effect is a hepatotoxicity that would require you to permanently stop the drug. So if you have a patient who also has hepatitis, you would like to know this. But another big reason is we actually could be providing appropriate therapy for these patients if we knew if they had both HIV, and again, here I'm just talking about hepatitis B. So lamivudine, many of you will know, is actually an active agent against hepatitis B. And guess what? It's part of our first-line regimen. Great, right? Well, the only problem with lamivudine, if you use it as a single agent against hepatitis B, you will pretty quickly develop drug-resistant mutations to that. It's typically generated quickly if you use it as a single agent. Well, just recently, in the last maybe year and a half, 2 years, we've gotten tenofovir. Tenofovir is also highly active against hepatitis B. And so this is something that we could actually use as part of a regimen for patients who are co-infected. Now, occasionally we know if a patient is co-infected, but usually we know because they come in with the belly out to here because of ascites. Usually somebody is tested because there are clear indications for doing so. But for the most part, we're not screening. We don't know. People can't afford to pay for the test themselves. So with children, some people might argue, well, can't really use tenofovir, is not FDA approved in children. Well, recently it was just approved down to the age of 12 in children or 35 kgs. So there certainly are possibilities there, and we are using it in some of our kids. So just a word about the vaccination policy in Tanzania. So as I said, Tanzania got the hepatitis B vaccine in 2002, so we haven't had it for that long. Here is a potential problem with the vaccine. There's no birth dose of hepatitis B vaccine in Tanzania, as in most of sub-Saharan Africa. Children are currently vaccinated at the age of 6 weeks as part of a pentavalent vaccine. They get Haemophilus influenza, hepatitis B, and diphtheria, pertussis, and tetanus, okay? Starting at 6 weeks. Now, why aren't we giving a birth dose? Well, again, it goes back to this. Most African children acquire hepatitis B by horizontal transmission and not vertical, so we don't need it. But again, we don't do anything to screen pregnant women for hepatitis B, so I would argue that we really don't know. And for me, it really just asks the question again, are we doing the right thing? Maybe we are. My study doesn't answer that question, but I think it's an area that we really need to look into. And the World Health Organization does recommend a birth dose of vaccine for any high prevalence country. And we've already seen that we are considered a high prevalence region. And it should be given within 24 hours. In this country, of course, you would give the vaccine and you would give a dose of hepatitis B immune globulin within 12 hours of birth. And if you didn't, you would very quickly have a malpractice suit on your hands. But again, only 5 countries in Africa currently have a birth dose of vaccine. And as I mentioned, a lot have chosen not to implement one, perhaps because of the horizontal transmission question. Logistically, I think for some places, it certainly would make it a bit more difficult. So again, I would like to know, we don't really know this. Should we be vaccinating children at birth? Should we be going back and vaccinating our HIV-infected children who did not receive the vaccine because of their age? And should we possibly be going back to target vaccine for anyone that was born after 2002? So I think I've given a lot of background as to why I wanted to do this study and the rationale for doing so. Certainly, interruption of vertical HBV transmission would be important. Again, I'm not able to answer that with this. But looking at optimal HPV vaccination policies, and I think very, very importantly, doing the right thing for our patients who are requiring antiviral therapy for both hepatitis and HIV. So, how did we do this? It was actually quite easy for me. There were 2 studies that had already been conducted that happened to have serum and plasma samples banked in our biotechnology laboratory. So for me, it was just something I walked into, was very fortunate to do so and to have access to these samples. The first study that we did, we had almost 400 samples from a study looking at pediatric normal ranges. So establishing hematology and immunology parameters for African children living in Tanzania. And this was done between December 2006 and March of 2008. As a requirement for participation in the study, all patients had to be HIV seronegative. Okay, so we know all of these children are uninfected. They were stored over the last few years at minus 40 degrees C. And then Elizabeth Reddy did a study looking at virologic failure on HIV-infected children on heart, and also had banked plasma samples for that. And her criteria were that children had to be on heart for a minimum of 6 months, anywhere from 1 month to 16 years, and they were stored at minus 80. The nice thing about the study is for both age groups, we have a very wide range, and I've divided that. When I get to the results, I'll show you that. So for testing, typically for screening purposes, people will use Hep B surface antigen. I also looked at core antibody, which can be a marker of acute and or chronic infection. This looked at total core antibody, and I point that out just because if you were looking at just an IgM, that would tell you whether or not they were acutely infected, and this is just a total core antibody, so it doesn't tell us about acute infection. Hep B surface antibody, which will tell us that a patient has either had the disease themselves, they've cleared it, and they're now immune to it, or they've been successfully vaccinated. Okay? And then an anti-HCV antibody, which was an ELISA that we did. Now, at the time we started this study, we were only doing the hepatitis B surface antigen in our laboratory, and this was an FDA-approved test. So the very first thing we had to do, and I think a critical step, was to do validation studies of all of these. And that actually took quite a long time, but we used only FDA-approved kits and spent several months doing our validation studies to make sure we could trust our results. And again, I just put this up here for review for anybody who wasn't familiar with the terminology. Basically, if you're negative for all 3 markers for hepatitis B, that means that you've never seen the disease, you've never seen the vaccine, okay? So you're susceptible. If you're hepatitis B surface antigen negative, but positive for core and positive for antibody, that means that you had the infection in the past, but you've cleared it and you're now immune. If you are positive only for HBs, the antibody, then that means you're immune because of vaccination. If you are positive on the first 3, then you're acutely infected. If you're chronically infected, you'll usually be positive for Hep B surface antigen and core antibody, which will persist. And again, as I said, most people for screening purposes will, if they're going to choose one, will use Hep B surface antigen. I don't have E antigen up here. If I had had enough money, I would have loved to have done E antigen testing because, as I said, that's a marker of active viral replication. So people who you really worry about are at the most risk of transmitting the infection to others. And so this is what we found. We had a pretty even split for males and females, 51% females. The median age was 8. I'll give you a breakdown on the next slide of our age groups. And we didn't see a single case of hepatitis C, which actually didn't surprise me. I didn't really expect to see any. But our hepatitis B was 12.5%, which I was I expected it to be relatively high, but that was higher than what I was, 12.5% is a lot. That confidence interval is 9.8 to 15.2. So, as I said, I haven't had a lot of time to really work with this data yet. So just a preliminary look. For children who were less than 12 months, we had only 44 in that age group. And I really wish we had more, but that's all we had. So prevalence there, we had 6 patients who were infected there, so that's 13.6%. The slide is perhaps a bit confusing. The 70% that says hepatitis B surface antibody positive, that's for all 44 of those patients had evidence of immunity, most of which was just surface antibody positive, so having been vaccinated. That's why I was looking at that. For children in the 1 to 5 year age group, we had 147. Only a few were infected, giving us 6.1%. And then you see in the older age groups, it's also quite high. So in the 5 to 13 year age group, which was our largest group with 262, we had 13.7%, and then almost 18% in the adolescents, 13 to 18 years of age. So again, when you're looking at these children in the 5 to 13 year age group, we're still doing our hepatitis B surface antibody testing, so I don't have all of those results yet. But what I have so far, only 12% of those have evidence of immunity. So, looking at just the children with HIV and hepatitis B, the majority of those were surface antigen positive. You can see on the right there were 3 who actually cleared their infection. They're now surface, is that right? Surface antigen positive? Yeah. Who are surface antigen negative, and these are also all surface antibody positive, indicating clearance of infection and now being immune to the disease. But if you compare the children with HIV, again, not a huge cohort, 161, if you compare those to the children who were uninfected, you see that children who did have HIV were more than 2.5 times as likely to be infected with hepatitis B. Again, these aren't huge numbers, but I think this has really important implications for what we're doing, particularly with our HIV-infected population. As I mentioned, perhaps we could go back and get a monovalent vaccine and vaccinate them. We certainly have drugs available that will address both infections. At the very least, we can monitor them closely to see if they develop signs of hepatotoxicity.
Andy, have you looked at confounders for that data?
I have not yet. I have not yet, no. I would very much like to do that. As I said, I've just gotten it. And we're still doing the surface antibody test, so I don't even have all of those in yet. Yeah. But I appreciate the comment, because as I said, I'm open to suggestions as we're really just getting into our analysis right now.
It'd be nice to look at regression, looking at the other factors that could have made a difference in these two. Because it's so important. Everybody's going to be asking you, okay,
right,
how sure are you that this is
right,
just HIV driving this and not some other factor?
Exactly. No, it's a great point. So, as I said, this sort of, implications for this, where do we go with this? As I said, this is very preliminary. We are currently getting ready to do another study in Kilimanjaro that Elizabeth Reddy will be working on among our adult patient population, which is quite a large sample size from the CHAT study.
It is.
But we're talking about, several hundred adult patients with HIV that we'll be doing comprehensive hepatitis testing on, to include e-antigen. So I think this data combined with hers will, I think, be quite important to get out there. I would in particular like to get this out to the Ministry of Health and to the National AIDS Control Program and see if we can get anywhere with influencing, perhaps recommending screening of HIV-infected patients. And then obviously there's a lot that still needs to be done. I can tell you this is a very big area of interest, not only at our site, but internationally. So the impact and ACTG networks are actually making hepatitis and HIV co-infection a focus, a priority area of research as they're developing their new research agendas for the coming years. So this is something that a lot of people are interested in. A lot of people keep remarking, we just don't have good data from sub-Saharan Africa. So, you know, this is something that will at least add a little bit to that. And I think most importantly, we really need to do studies among pregnant women and figure out, you know, is our vaccination strategy optimal right now, or are we completely missing the boat and we need to go back and redo things?
What about viral loads? We know that if you take a person who you're treating with an HIV co-infection, and you drop their HIV viral load, will you drop their hepatitis B viral load?
Not necessarily. It depends on if they're on drugs that are active for their hepatitis B.
Yeah, I'm trying to figure out if there's an independent factor of just the immune modulation, and not a direct effect of the drugs themselves.
Yeah.
Do we know anything about that?
You know, I personally don't. It's a great question. I don't.
It'd be
It's something
easier to
people
do
can
it that way than to do it going up, as
Yeah.
catch it, acquire HIV, does their viral load for, Hep B go up?
Right.
But it's hard to capture those things.
Right. And I'm not sure if with the adult data, are they going to look at viral loads as well? They
Yes.
might be. Okay.
Yes.
Okay.
Yeah, Ralph, there are a couple of different observations that are important with regard to your question. First of all, as Annie mentioned earlier, you can actually see an immune reconstitution exacerbation of chronic hepatitis in some patients. But then if you follow people over the longer term, especially in the context of hepatitis C, someone who's co-infected on antiretroviral treatment has a better outcome. So independent of Hep C
Better
treatment.
outcome for the Hep C.
Yes.
Good. That would really
Yeah.
back up all this stuff. How
Yeah.
important it is.
Yeah, that's great.
And
Yeah.
I have a question about, talking about viral load. If it's possible to take some of the dried blood spot samples
Right.
from some of these infants and look for HBV viral load, and if there are any archives there that you can use for that purpose, and then compare it
Yeah.
to the percent that you're seeing and see, is this vertical or is this horizontal?
Right. No, it's a great idea. As you know, the challenge is with getting access to those samples and approval to send them anywhere. But I think it's a great idea. Yeah.
The Abbott M2000, if you have the right set of primers, can do Hep B DNA levels.
I was just wondering if there were any archives from the old dried blood spot.
Oh, from Sarah
study.
Lofgren's
Yeah, from
study?
Sarah's, and if that was something that could possibly
Yeah.
be used rather than trying to get it from the national, which would be definitely more challenging.
Right. Right. No, it's a great idea. That's my
Hey,
son.
Thomas.
Had to end with the photo of him.
What a great.
Annie, where do you plan to present these data,
Well,
other than DJHI?
right. We had, thank you, we had talked about trying to get it into Croy, but we're too late for that. So I guess the next one after that is
The World AIDS Conference.
in July, right?
Uh-huh.
Yeah, yeah.
Uh-huh.
I think that's what we'll try for. We'll also be doing our PMTCT data there, hopefully.
Uh-huh.
Yeah.
So I'd like to put in a shameless promotion here that
Okay.
the funding for this came from many different sources.
Yes.
But some of it came through a transition award to
Thank you.
Florida Murrow.
Yes.
So there is DJHI's support for this project.
Absolutely. Thank you, John. I should have mentioned, I mean, one of the things we always try to do at KCMC is to work alongside a Tanzanian colleague. And Florida Muro is very much my colleague in this. Florida did her MPH and then was awarded a DGHI transitional grant. And I was awarded a CFAR grant, and we actually, neither one of us had enough money to do this alone, and we combined our resources, and it really has been a team effort. So thanks for reminding me of that.